So we know that human papillomavirus, or HPV, is the primary cause of most cervical cancers. HPV infection is extremely common, but it's usually transient. So most cervical cancer is caused by persistent infection with HPV that lasts for many years. And in addition to cervical cancer screening with Pap tests, HPV DNA tests are being increasingly used in screening. And those tests help detect persistent HPV infection and then the subsequent cervical abnormalities. We also have HPV vaccines now available to prevent the initial infection with the types of HPV that most commonly cause cervical cancer. Today, my talk will cover cervical cancer incidence and mortality rates, screening, and a little bit about HPV vaccination among American Indian and Alaska Native women. So first, I'll talk a little bit about cervical cancer incidence and mortality. This chart shows publicly available data on overall cervical cancer incidence statistics. This is from 2007 to 2011. This is from the U.S. Cancer Statistics Report that's put out by CDC. It's available online. And you can see from this chart that Hispanic and Black women have the highest rates of cervical cancer, and rates appear to be relatively similar between Alaska Native and American Indian women and white women. And this chart shows overall rates of death due to cervical cancer during the same years, 2007 to 2011. And again, looking at this chart, it appears that Hispanic and Black women have higher death rates, and rates appear to be similar for American Indian and Alaska Native women and white women, although slightly higher for American Indian women. However, there are several issues with reporting on cancer incidence and mortality among American Indian and Alaska Native populations because American Indian ancestry is often underreported in medical records and in death certificates. We know that this problem is especially common in regions with small American Indian populations or in urban areas where fewer American Indian and Alaska Native people rely on the Indian Health Service for their medical needs. So misclassification of Native ancestry is less of a problem in the 637 Indian Health Service Contract Health Service Delivery Area counties, or CHSDA counties, where 64% of American Indians live. Recent efforts have improved identification of Native populations in federal data. CDC and the Indian Health Service recently have collaborated to link mortality data from CDC's National Center for Health Statistics, Indian Health Service records, and previously did the same for cancer incidence data. And I believe my colleague David Espy presented a webinar to this group on identification of American Indian and Alaska Native populations in the cancer incidence and mortality data back in June. So results of the Indian Health Service and death data linkage were published earlier this year in a recent supplement issue of the American Journal of Public Health. I know, again, this was presented earlier this year to this group. That journal is online, and it's free, has free online access, so everyone should be able to see those articles there. Although the data that was used in the supplement came from the same source as the U.S. Cancer Statistics Report data that I just showed you, we did make several refinements to ensure better identification of American Indian and Alaska Native populations in the linkage and then in the resulting articles. So I'll share results from the cervical cancer paper from this supplement with you. Non-Hispanic whites were used as the referent group for comparisons. And because of some issues with Hispanic, American Indian, and Alaska Native populations in the census data, we limited our analysis of AIAN populations to non-Hispanic groups. Another way the articles in the American Journal of Public Health supplement provided better data on AIAN populations was by focusing on the CHSDA areas where we know that identification of American Indian and Alaska Native populations is improved. This map shows the CHSDA areas as well as Indian Health Service regions that we used in the publication. Some of the data I'll present shortly on cancer incidence and death rates use the regional groupings shown on this map. And this slide just shows the title and first page of the cervical cancer incidence mortality paper that was from the AJPH supplement. In the next few slides, I'll be presenting use data from this paper. This slide shows overall rates of cervical cancer incidence among American Indian, Alaska Native women and non-Hispanic white women as the comparison group. In CHSDA areas, which you can see on the left of the slide, where identification of AIAN populations is highest, American Indian, Alaska Native women had a rate of 11 per 100,000 for cervical cancer, and that's compared to 7.1 per 100,000 for white women. This chart shows cervical cancer incidence by age for American Indian, Alaska Native women and white women. The bars that are marked with an asterisk show that the difference between rates for AIAN and white women was statistically significant. So in CHSDA areas, again on the left, rates were higher among American Indian women across all age groups, with the highest rates among the oldest women. Among white women, rates peaked in midlife and then declined with age. This disparity is likely related to less screening among American Indian and Alaska Native women throughout their lifetime. This chart shows cervical cancer incidence rates in the Indian Health Service regions that I showed on the map previously. So when limited to the CHSDA areas, rates were significantly higher in all regions except the East. Rates were highest for American Indian and Alaska Native women in the Southern Plains, followed by the Northern Plains and Alaska. The next few slides will show death rates from cervical cancer, again from the article we published in the American Journal of Public Health supplement. In the CHSDA areas, American Indian and Alaska Native women died from cervical cancer at more than twice the rate of white women. This chart shows cervical cancer cervical cancer death rates by age, which were higher among American Indian and Alaska Native women than whites of all age groups, and markedly higher again among women aged 85 and older. This chart shows cervical cancer death rates by Indian Health Service region. In the CHSDA areas, although rates were higher across all regions for American Indian and Alaska Native women, differences in rates were statistically significant in the Northern Plains, Southern Plains, and Southwest regions. This chart shows trends over time in cervical cancer death rates among American Indian and Alaska Native women compared with white women from 1990 to 2009. We used Joinpoint analysis, which detects trends within time periods. And you can see on this slide that cervical cancer deaths among white women declined slowly but steadily during this time period, while cervical cancer deaths among American Indian and Alaska Native women dropped steeply in the early 1990s and then tended to somewhat level off. Several federal activities were likely related to the decline in cervical cancer in the early 90s. For example, the Indian Health Service began providing cervical cancer screening to Native women in the 1960s and 1970s, which led to decreases in cervical cancer incidence and mortality by the 1980s and 1990s. Congress also passed the Breast and Cervical Cancer Mortality Prevention Act of 1990, which established the CDC's National Breast and Cervical Cancer Early Detection Program. That program provides access to breast and cervical cancer screening and diagnostic services to underserved women. In order to address continuing disparities, the 1993 reauthorization of the Act included amendments directing the CDC to establish a program with tribes and tribal organizations with the goal of increasing screening in tribal communities. A recent study found that 36% of eligible American Indian and Alaska Native women were screened through the National Breast and Cervical Cancer Early Detection Program, and that was higher than any other group. This program funds tribes and tribal organizations to provide screening services for breast and cervical cancer, but also partners with tribal programs, state partners, and others to increase outreach and education, specifically to American Indian and Alaska Native women on the need of preventive care and cervical screening. Now I'll provide a brief overview of cervical cancer screening. Just to remind everyone of the current cervical cancer screening guidelines, women should be screened with a Pap test every 3 years starting at age 21. At age 30, women can choose to continue getting screened with a Pap test every 3 years or with a Pap test and an HPV test every 5 years. And these intervals, just to clarify, are based on normal or negative results and apply to those women with an intact cervix. Women with a history of adequate screening and normal results can stop being screened at age 65. Federal data on cervical cancer screening often come from the Behavioral Risk Factor Surveillance System. That's the world's largest ongoing telephone health survey system, and these data are self-reported. According to BRFSS data, published in another paper that was included in the American Journal of Public Health Supplement, in CHSDA areas, nearly 80% of American Indian and Alaska Native women reported being screened for cervical cancer within the past 3 years, and that was nearly the rate of white women, although the difference was statistically significant. By region, women in the Southern Plains and Southwest regions reported being screened less frequently than white women. However, medical data from the Indian Health Service and required by the Government Performance and Results Act tell a different story. And again, these are slightly different populations. So BRFSS is the whole United States, where this is only people in the IHS records. In 2012, only 57% of eligible women receiving Indian Health Services had been screened for cervical cancer within the past 3 years, and that was well below the IHS goal and the Healthy People 2020 objective of 93% screened. And screening rates appeared to decline somewhat over time, although we did not do statistical testing for this graph, and also beginning in 2010, refusals for Pap testing were removed from the rates. So the 2002 to 2009 rates in this graph cannot be compared with the 2010 to 2012 rates. And this slide just shows a little bit of a closer look at cervical screening by region. Note that these are different regions than those previously shown. Screening varied by region, with rates close to 70% in a couple of regions like Alaska and Albuquerque, and less than 60% in some other areas. Now I'll talk about HPV vaccination. As I mentioned before, HPV is the primary cause of most cervical cancers, and HPV vaccines prevent infection with the types of the virus that most commonly cause cancer. HPV vaccination is recommended for adolescents of both sexes at age 11 or 12. The vaccine requires 3 doses. Providers can vaccinate as young as age 9, or for those who were not vaccinated at younger ages, up to age 26 for women and age 21 for men. All children who are members of federally recognized tribes and eligible for IHS services are also eligible for the Vaccines for Children program, which covers the entire cost of the vaccine. CDC has engaged in some special outreach to make sure that Native families are aware of the availability of the vaccine. And I've put a link to a website there, but also I wanted to show you just one of the posters that was created to increase awareness of the availability of the HPV vaccine. This poster was created specifically for the Southwest region. This chart shows data from the National Immunization Survey-Teen from 2013. The National Immunization Survey, or NIS, is a telephone survey followed by a mailed survey to children's immunization providers to monitor childhood immunization coverage, and it provides population-based estimates. This chart shows HPV immunization rates among girls aged 13 to 17. American Indian and Alaska Native teens had the highest rates of receiving 1 dose of the vaccine at 73%, and 43% had received all 3 doses of the vaccine. The Indian Health Service also provides data on vaccination levels among its patient population. Among female IHS users aged 13 to 17, 83% had had at least one dose of an HPV vaccine and 59% received all 3 doses. And again, this was higher than the number for American Indians and Alaska Natives reported in the National Immunization Survey. This chart shows IHS data on HPV vaccination, but among adult women who are still recommended for vaccination at age 19 to 26. 53% of these women had received 1 dose and 35% had received all 3 doses. And there were some variations by region. So in conclusion, most cervical cancer cases and deaths are preventable, and when we have disparities, that shows missed opportunities for prevention. First of all, we need to be sure to interpret data for American Indian and Alaska Native populations with caution, because data that are not produced with the goal of focusing on Native populations may be misleading or may mask disparities, as we saw with some of the incidence and mortality data, and as Dr. David Espy had discussed earlier. Although cervical cancer has been improving overall in the U.S. and among Native women, we still see ongoing disparities, showing that we have more work to do. Screening rates among American Indian and Alaska Native women remain low. We need to continue to identify and address the geographic, financial, and bureaucratic barriers that AIAN women face in order to improve screening rates. Differences between self-reported screening data and medical records suggest that some AIAN women may incorrectly believe that they have been recently screened. American Indian and Alaska Native women aged 85 and older have very high rates of cervical cancer incidence and deaths. Providers should keep in mind that the recommendation not to screen women over age 65 only applies to women who have been adequately screened in the past. Efforts to increase cervical screening among AIAN women should include women who have passed their reproductive years. And finally, HPV vaccines show promise in reducing cervical cancer among younger generations of women. However, HPV vaccination rates in the United States are generally low, and there's much room for improvement. It's also important to remember that vaccinated women still need to be screened. So just wrapping up, I don't know whether this PowerPoint will be distributed to those who are participating, but if so, I included several links to articles here where I got the data and that may be helpful for you. And now we can move on to questions.
Yes, Meg, we will be distributing the PowerPoint presentation via Keep It Sacred. Also, everyone that participated today will receive an email containing the links directly to the presentation. And we are recording this webinar, and we'll be making that available as well. Excuse me. Now we will also turn the time over to questions. So who has questions for Meg? And like I said, there's a couple of ways we can do that. You can either press the raise your hand button and I can unmute you if you'd like to, if you've got audio capabilities. But if you don't, please don't hesitate to type your question or email it to us and I can read it to Meg. And then for those without audio capabilities. We'll give you a few minutes to type if you need that. One moment. All right. We have a question from Aubrey. I'm going to unmute you. Are you there?
Hi, can you hear me? I'm not sure if I have a microphone.
We can hear you. Oh, sorry.
Okay, wonderful. Hi, Meg. Thank you for the presentation. Just a quick question in terms of what recommendations CDC may have for strategies for increasing vaccination in this population, particularly related to what providers might be encouraged to do or how we could go about getting providers to act to help increase vaccination rates.
That's a great question. I work in cancer, so I am less familiar with everything that our vaccination group has. We do have a specific website on vaccines, so I think I'm going to try to check there. I don't know if you can see my screen.
I can.
But I know that there are activities going on, as I showed the poster, and I would love to see specific recommendations targeted for providers, but I am just not really sure about what they have, and I apologize for that.
Okay, well, perhaps if there's contact information for the individuals at that branch, that might be helpful to have.
Yeah, you know, I think what would be best is if you can follow up with an email to me, and then I can have some time to figure out who to get you in touch with.
Sure, that would be great. Thank you so much.
We have a question from Dr. Espy. One moment.
Hi, this is David Espy. This is just in response to Audrey's question, and one very good contact person for that question would be Amy Groom, who is the immunization coordinator for IHS, who's assigned from CDC's NCIRD, and she's quite active with her group here, and she works very closely with all the areas and many of the service units to promote vaccine uptake, not only HPV but all recommended vaccinations. But we can include her contact information in Meg's response to you.
Thank you, Dr. Espy.
Other questions for Meg? Oh, one moment. We have one someone who's typed one. C.K. Smith asks, do you have any information on, I'm going to mispronounce this, oropharyngeal cancer rates among AIAN people, since there may be a link between the vaccine and prevention of this type of cancer as well?
That's a tricky one. David, was there an article in the supplement on oropharyngeal cancer?
Can you hear me?
Yes, sir.
Hi. There was not. We did include an article in the previous supplement in the journal Cancer that just covered incidence data through 2004, and the rates are very elevated, and we knew this prior to the publication in Alaska and a couple of other areas, but we did not include one this time around, and that's actually a very good question that we should address, and we are doing several follow-up articles on some topics that were not included in the supplement, and this is a good candidate for inclusion in that group.
Thank you. Yeah, and oropharyngeal is a little bit of a tricky one because it is often linked with HPV, but also often linked with tobacco and alcohol. So it's one of the ones that it's a little bit less, the etiology is a little bit less clear. It seems to have a lot of things that can sort of increase the risk.
Okay, other questions for Meg? Oh, sorry. There's a bit of commotion in the office. Okay, as I said, you can type out your question if you have one, or you can raise the hand button and you can be unmuted individually. And we would like to thank Meg for her presentation, and like I said, we will be making this presentation PowerPoint as a PDF available via Keep It Sacred. Oh, one moment. And we will also be making this recording of the presentation available. And that will you'll all receive an email containing those links within the next 48 hours. It will also contain a link directly to the webinar evaluation, which we all know how important those are. We do have a question from Sam Mooneyhan. I apologize if I mispronounce your name. They ask, are there successful campaigns that you know of that target vaccinations for boys? Our state has lower rates for vaccinations of boys versus girls.
I don't know of any successful campaigns. As far as anything I've seen, the rates are still pretty low. They are going up. You know, and the American Indian and Alaska Native groups generally had fairly high rates overall compared to other groups. I did pull some just male vaccination data that I can show you. This shows data from the National Immunization Survey among boys. That was really low for American Indian and Alaska Native. Actually, the 3 doses was so low that it didn't give me a rate. And then this shows Indian Health Service data, which was quite a bit higher. This is 13 to 17, and this is 19 to 21, which is lower. So to me, from just looking at the data that I've seen, that I've pulled, it looks to me that the Indian Health Service has about the highest rates for males that I've generally seen. And I think that's because, you know, it's just they are set up to do it. They have the vaccines. They work well with the Vaccines for Children program, and they're, you know, that it's free. So I don't know of how they're running their specific outreach, though. If anybody on the phone knows more about that, please feel free to chip in.
Yes, please, if you have something you'd like to add, don't hesitate to raise your hand. We can unmute you. Oh, Dr. Espy, one moment.
Claim to know a lot about it other than the fact that it is an integrated healthcare system with a unifying electronic medical record and sort of a very strong public health approach to the whole immunization program. And all of these things, I think, contribute to success, not only with HPV, but other vaccinations. And so it's always been a priority for the Indian Health Service and tribal programs supported through IHS to have a robust immunization program and a robust prevention program overall. So I think these speak to the value of having an integrated healthcare system.
Other questions for Meg? Okay. As I said, we will be sending out the evaluation and links to all of the information presented today within the next 48 hours. And we'd also especially like to thank Meg Watson for her time and for this informative presentation on cervical cancer and the HPV virus, or rather HPV. And if there are no further questions, we will adjourn early for today. And on behalf of the National Native Network, we'd like to thank you so very much for your attendance, and we'd like to thank Meg for her participation and her presentation. Thank you.
Thank you.